session, please give it up for the Pediatric Orthopedic Society of the Philippines to be moderated by Dr. Nesty James Panopio.
Good afternoon, everyone. Can you hear me? Once again, I'm Dr. Nesty James Panopio. I will be your moderator for today's Pediatric Orthopedic Society of the Philippines part of the POA Convention lectures. So good afternoon again to everybody. So for this afternoon, for our pediatric section part, we will have a very amazing core lectures to be presented by our distinguished guests, distinguished speakers for this afternoon. And the four speakers are the following. The first speaker is Dr. Rosalyn Roti Flores. Dr. Roti completed orthopedic residency training at the University of Santo Tomas, Manila, and was awarded as an outstanding resident by the PBO during her second to fourth year level. She had her fellowship training for pediatric orthopedics at the National University Hospital, Singapore, and for Elisarov and limb deformity surgery at the University of the Philippines, Philippine General Hospital. She underwent several training pertaining to Ponseti clubfoot treatment and research center at the University of Iowa, USA. She is currently affiliated with the following institution: St. Luke's Medical Center, Global City, Rizal Medical Center, assistant professor at the University of Santo Tomas, Faculty of Medicine and Surgery, and as a consultant to nonprofit organization, primarily with clubfoot treatment, the Miracle Feet, the Philippine National Clubfoot Program, and the Philippine Clubfoot Resource Center. The second speaker for this afternoon is our very own Dr. Carlo Emanuel Sumpayco. He is a consultant pediatric orthopedic surgeon who heads the pediatric orthopedic section from both Philippine General Hospital and the Medical City. He finished his residency training from the Philippine General Hospital and furthered his studies as a clinical fellow in pediatric orthopedics from the Royal Hospital for Sick Children in Glasgow, Scotland. He is an adjunct associate professor from the Orthopedic and Rehabilitation Engineering Center in Marquette University, USA, and the Medical College of Wisconsin. He is also the director of the Motion Analysis Program, or GATE Lab, of the Philippine General Hospital. His special interest in pediatric ortho includes DDH, cerebral palsy, and clubfoot. The third speaker is Dr. Juan Alejandro Legaspi. Dr. Al Legaspi graduated from De La Salle University College of Medicine and finished his residency training in orthopedic surgery from Jose Reyes Memorial Medical Center. He had his fellowship training in pediatric orthopedics at the Duchess of Kent Children's Hospital under the Department of Orthopedics, University of Hong Kong. Currently, he is the Vice Chairman of the Department of Orthopedics and Section Chief of Pediatric Orthopedics at Jose Reyes Memorial Medical Center. He is the incumbent president of the Pediatric Orthopedic Society of the Philippines. The last speaker for today is Dr. Candice Lim. Dr. Candice Lim finished his med school at the University of the East Medical Center and finished her residency at the Medical City, did her fellowship training in pediatric orthopedics at Seoul National University Children's Hospital, Seoul, South Korea, and also did her AO trauma subspecialty in hospital for special surgery, New York. So friends, welcome to the POSP section of the POA convention. We hope that you will enjoy this day. Thank you.
Hello, hello everyone. I am Dr. Rosalind Flores, and today I will be talking about the strategies our clubfoot clinics employed to ensure continuity of care for our patients during the pandemic. As my disclosure, these are the different clubfoot programs I am currently working with. The unprecedented nature of the pandemic presented us with unique challenges that hindered continuity of care for our patients. The more common challenges include issues pertaining to COVID-19 infection prevention, the initiation and continuity of treatment for clubfoot patients, prevention of relapse, continued parent education, and training of treatment providers in order to ensure the delivery of quality service in the clubfoot clinic. I will be presenting how our network of clubfoot clinics were able to adapt, thereby addressing these challenges during the height of the pandemic. A major challenge that needed to be addressed was how to prevent the spread of COVID-19 infection. This challenge, however, was not exclusive to clubfoot clinics given the global extent of the crisis. In response to the massive demands on the healthcare community brought about by the pandemic, there was temporary closure of clubfoot clinics. National quarantine restrictions limited patient mobility, so clinics initially saw online consultations and social media engagement as a temporary way to keep in touch with the patients. Some parents might not have enough load to send a text message or call, but they have free data which enabled them to send a message to the clinic's page. Even before the pandemic, all partner clinics were encouraged to put up a Facebook page, and COVID gave that extra push for all clinics to be more visible and more engaging in social media. Once restrictions were eased, clinics gradually started to reopen. In preparation for this, some clinics were retrofitted with physical barriers and other items to promote social distancing. When vaccines became available, clinic staff and healthcare providers were encouraged to get immunized against COVID-19. Health protocols for clinic visits were imposed based on hospital recommendations, and the use of personal protective equipment became standard when interacting with patients. Another important challenge that needed to be addressed was how to initiate treatment in new patients and how to continue treatment in patients that have already been enrolled in the program. We know that timeliness is an important consideration in initiating clubfoot treatment, since a delay in treatment can translate to serious consequences. Fortunately, because of the social media presence of the different clinics, parents are able to communicate with the clinic and send inquiries, and initial evaluations were often done online. Subsequent clinic visits were then done on a by-appointment basis. Face-to-face consultations observed COVID-19 guidelines following recommended hospital protocols. In order to continue treatment in patients that have already begun the casting and bracing phase, some clinics needed to open additional clubfoot clinic days in order for proper social distancing to be observed. Also, partner clinics like Philippine General Hospital and Zamboanga City Medical Center established satellite clinics as an extension of the main clubfoot clinic in order to reach patients that were unable to get to the main clinic. PGH tapped into their ortho alumni practicing in Nueva Ecija, Laguna, and other areas, and they were able to treat patients in their private clinics free of charge. Also, at the beginning of the pandemic, when online consultations were seen as a temporary solution, it eventually became recognized as a tool that is here to stay in order to keep in touch with patients and ensure regular follow-up, translating to a decrease in dropout rates. Additional issues that were highly anticipated at the beginning of the pandemic included increased dropout rates and the high risk for recurrence of deformities or relapse. Now that online consultation has been established as a regular means of communicating with parents, in majority of the cases, brace follow-up was done via video calls in order to monitor for any signs of relapse remotely. In cases wherein braces needed to be exchanged for a different size, the braces were sent via local couriers. I will now show a short film featuring the team from Benguet who tapped into their passion for biking to reach patients in geographically isolated areas.
When COVID hit, it obviously affected everything. The quarantine status of the community meant that mobility was limited. Patients, they're not able to leave their houses. They're not allowed to go into town.
As of the moment, we have 60 patients on the list. Most of them are unable to come to the clinic because of the pandemic.
Our clinic is at Benguet General Hospital. We're on the southern part of the Cordilleras. We've been seeing patients with clubfoot deformities since 20 years ago when I started practice. What's the effect of an untreated clubfoot? It leads to an unsightly deformity. As the patient grows, he gets teased by his classmates, by his friends. They usually have a loss of self-esteem. A lot of them drop out of school. And it's also been linked to abuse. I am JP Leong. I'm an orthopedic surgeon.
I'm Haya. I'm a physical therapist. Clubfoot is treatable. They have to keep the correction achieved during the first 2 months of treatment by using the brace because it's very noticeable. When they don't wear the brace, you see a change right away. That's when we decided to bring the braces to them by biking. Some of the municipalities are locked down, but they allow the bikers to pass by. So we thought of just bringing the brace to them.
We're not super hardcore bikers. We can't like bike 100K, but we can drive to a certain area and then bike once we get there. It's a very rough terrain, a lot of very mountainous and hilly terrain. And this makes it challenging for patients to reach healthcare. We saw some of the patients on the list, and they actually lived in communities which were reachable by bicycle. When we go for our weekend rides, we'd arrange to meet up in a certain area, do a brace exchange or a shoe bar exchange. They have to maintain the brace until the child reaches a certain age. There's a high recurrence rate because the children's foot is still growing.
So, hindi na po siya tutuksohin paglaki niya.
One of the biggest obstacles was really access. And so, since that's one of the things that we can control, or something that's within our power to control, it's something we tried to do.
Another challenge that needed to be addressed was the need for continuous parent education. Using the Facebook page of the clinics, parent education materials were regularly posted, and online activities by the different clinics to celebrate World Clubfoot Day were also used for parent education. The Philippine National Clubfoot Program also launched a Facebook Live series that discussed clubfoot and clubfoot treatment, with an opportunity for the parents to engage in a live question and answer with the doctor. Finally, in order to ensure quality service delivered by the different clinics, there is a need to ensure continuous training of the treatment providers at the clubfoot clinic. Effective clubfoot treatment using the Ponseti method requires standardized training and ongoing mentoring of healthcare providers. Limitations to face-to-face training courses include the following: limited time for covering extensive theory and hands-on practice, short resident rotations and frequent turnover of orthopedic residents in training, and inability to run the course where travel restrictions and social gathering limitations are in place, as what has happened for the past 2 years in light of the pandemic. It is because of these limitations that alternative methods of training providers needed to be explored. As a short background, Global Clubfoot Training is a complete set of teaching resources developed in 2018 and adapted from the Africa Clubfoot Training course materials. The basic provider course is delivered face-to-face with practical sessions incorporated within the training, which generally include manipulation and casting using clubfoot models and treatment demonstrations with patients. In preparation for the blended learning approach, the following online resources were developed: an e-learning platform which drew content from the basic course training package of the GCT curriculum, including text, illustrations, animations, and quizzes, and animated models that demonstrate the anatomy of the foot, both normal and the clubfoot, and the various steps of the Ponseti manipulation. These online resources were combined with additional online activities, which include synchronous video conferencing sessions to facilitate large and small group discussions, and asynchronous practical skills exercises focusing mainly on manipulation and casting of rubber foot models to complete the blended learning course. Miracle Feet and Global Clubfoot Initiative conducted 4 trainings from 2020 to 2021. A total of 56 healthcare providers from 17 training sites from the Philippines and Zimbabwe were trained during the pilot. The participants had varied backgrounds. Majority were orthopedic surgeons, comprising 59% of the participants, followed by physical therapists, comprising 20%, and occupational therapists at 9%. Majority of the participants had previous experience with e-learning methods. Looking at the results of the pilot, there was improvement in the knowledge of the participants. The mean score on a 12-question test of knowledge related to clubfoot treatment was significantly higher post-course compared to the baseline for all 4 cohorts using a paired t-test for analysis. The participants' confidence also increased. The mean score on a 10-item scale measuring confidence with different aspects of clubfoot treatment was significantly higher post-course compared to baseline for all 4 cohorts using a paired t-test for analysis. Based on the pilot, it can be seen that blended learning holds great promise in enhancing the quality and accessibility of training in clubfoot management, as the increase in participants' knowledge and confidence is comparable to face-to-face trainings, and thus may be used in situations where face-to-face trainings may not be feasible. To conclude, these are the lessons we learned in order to ensure continuity of care for clubfoot patients during the pandemic. Definitely the most important is to prioritize health and safety, not only of the patients, but also of the parents and the healthcare providers by establishing health protocols that minimize the spread of COVID-19. Next, we should maximize the use of available platforms and resources. Social media, online consultation platforms, and video conferencing tools have played a huge role, not only in the management of clubfoot patients, but other orthopedic patients as well. The use of these may go well beyond the pandemic period and can be incorporated into regular clinic operations. And finally, do not be afraid to think outside the box. If we keep our sights set on delivering service to our patients, this will fuel the fire of creativity and inventiveness. As we come to the end of my talk, I hope this has inspired some of you to become a pediatric orthopod, just like us, or to become part of our thriving clubfoot family, or maybe even relocate to Benguet and take up biking. Have a great day ahead and maraming salamat sa inyong lahat.
The percutaneous Achilles tendon tenotomy may be one of the hardest procedures in the treatment of clubfoot because the child is awake and usually relies on local or topical anesthesia for the procedure, and the tenotomy takes place in the vicinity of the neurovascular structures behind the medial malleolus. What makes the percutaneous Achilles tendon tenotomy tricky is because the Achilles tendon lies in the vicinity of your neurovascular bundle. This is a description or a picture of the medial side of the foot. So you can see the Achilles tendon marked in gray is near the neurovascular bundle behind your medial malleolus. There is a certain degree of anxiety, both from the parents and the doctor, because the baby is awake during the procedure. These anxiety levels are further elevated when the procedures are done by residents in the different training institutions. The resident may be anxious because the baby is awake and also because they are novices to the procedure. I am sure the anxiety is further elevated when there is a consultant in the room hovering, pacing back and forth for fear of complications. As an educator in pediatric orthopedics, the percutaneous Achilles tendon tenotomy is a challenging procedure to demonstrate or teach. Because of its proximity to the neurovascular bundle, because of the child who may be struggling or uncooperative, and the inherent difficulty in the ability to describe or convey the feel of the cut of the Achilles tendon. I'm Carlo Emanuel Sumpaico, a pediatric orthopedic surgeon. I would like to discuss a model for the Achilles tendon tenotomy for clubfoot, which I call the Adidas solution. Nope, not this kind of Adidas, but this one, the humble chicken feet. The new model uses a chicken foot for simulating the Achilles tendon tenotomy for clubfoot to demonstrate the proper feel of the cut without the dangers of iatrogenic injury to the neurovascular bundle and without the difficulties encountered with an uncooperative or struggling child. So why the chicken feet? Well, it is readily available in your local market. It is very cheap. The size of the flexor tendons of the chicken foot are similar to humans. And because there are a lot of tendons per foot. As you can see here, in humans, we have 2 flexor tendons of each finger, while in the chicken, we have 3, namely your flexor profundus, your flexor superficialis, and your flexor perforatus. The Adidas solution comes in 2 parts. Didactics, wherein we discuss the indications for percutaneous tenotomy, we list down the materials needed for the procedure, and we practice the identification of landmarks for the percutaneous tenotomy. Then, we proceed to the step-by-step procedure to experience the feel of the cut. So this is a slide showing when the foot is ready for tenotomy. The talar head should be covered. The foot can be abducted to 50 to 70 degrees, and the heel is in valgus or at least neutral after correction. This is a slide for the preparation of materials. You would need a chicken foot, a blade 11 or stab knife, and its corresponding knife handle, a mosquito, and a pair of gloves. Now we come to the exciting part. First, the tendon is grasped through the chicken feet. Once it is grasped, it is secured with a mosquito. Next, keeping the tendon taut using the mosquito, the tendon is palpated, just like in the normal foot. The blade is inserted anterior to the tendon, just like in the normal foot, and the blade is twisted 90 degrees towards the posterior, just like in the normal foot, and the tendon is cut. Once again, the tendon is kept taut by the mosquito. The tendon is palpated using your index finger. The blade is inserted anterior to the tendon. And it is twisted 90 degrees to cut the tendon. There, you can see the sudden give of the tendon, signifying that it has been cut. And to see how the tenotomy experience went, we asked for feedback. We did a pilot study comprising of 9 questions to ask about the theoretical aspect of the percutaneous Achilles tendon tenotomy, namely the indications, material preparation, and the visualization of all steps in the procedure. We also asked about the practical aspect of the tenotomy, the identification of landmarks, the simulation of blade placement, and the actual cut of the tendon. We had a total of 12 respondees. All of them said that the new training method helped them know the indications for the procedure. All of them said that the new training method for Achilles tendon tenotomy helped them prepare all the materials needed. All of them said that the new training method helped them visualize all the steps needed for the actual tenotomy of patients with clubfoot. 11 out of the 12 respondees said that the new training method for the Achilles tendon tenotomy helped them identify all the important landmarks for the actual tenotomy of patients with clubfoot. All respondents said that the new training method simulated the actual blade placement in patients with clubfoot. All of them said that the feel or give of the Achilles tendon being cut in the new training method is the same as the actual feel or give in an actual patient with clubfoot. Everyone said that the training method for Achilles tendon tenotomy decreased their level of anxiety or nervousness for the actual tenotomy in patients with clubfoot. All of them said that overall, the new training method for Achilles tendon tenotomy using chicken feet prepared them for the actual tenotomy in a patient with clubfoot. All of them highly recommended or strongly agreed that they will recommend the new training technique to other healthcare professionals treating patients with clubfoot. So as a summary, the new model for tenotomy was well received. It helped them in the preparation for the actual procedure. It simulated the actual tendon being cut, and they would all recommend it to others. So what is the future direction for this new learning technique? Well, we can make it pandemic-proof through remote learning. You just need the chicken feet and the materials, as well as a Zoom account, as seen here. I am in another location while the residents are in the department doing the chicken feet simulation. Another future direction is the development of a chicken foot holder to include the landmarks of the human foot, namely your lateral malleolus, so that the lateral talar head can be identified, and the calcaneus, so that the Achilles tendon can be identified easily. So this is a picture of the chicken foot inside the holder. You can see the index finger palpating the Achilles tendon, while the other hand is dorsiflexing the foot, simulating what is being done in real life. And this is how the procedure goes. Tendon is palpated, blade is inserted, twisted 90 degrees, and the tendon is cut. Thank you very much.
Good morning. Distal radial fracture is one of the most common long bone fracture in children. It accounts to almost 40% of all pediatric fractures. The usual mechanism of injury is fall on an outstretched hand. You can have either apex dorsal or apex volar, depending on the position of the wrist during the fall. This is more common in prepubescent boys and girls because metaphysis is relatively thin and porous. The different types and degree of displacement is dependent on the velocity and height of the fall. Here is a common picture that we see with patients having a distal radial fracture. And like all long bone injuries, it is important to rule out an open fracture. Plain and X-ray is almost all you need to diagnose a distal radial fracture. The goal of treatment is to achieve bony union within acceptable radiographic parameters to achieve long-term function and avoid complications. Choice of treatment is influenced tremendously by the remodeling potential of the distal radius in growing children. Looking at the classic paper by Freiberg, remodeling is brought about by the combined effects of the direction and amount of ICL growth. According to Riopi, on the alteration of epiphyseal growth during the remodeling phase, wherein the asymmetric growth of epiphyseal plate is responsible for 80% of the remodeling. So what to do, especially in those times of lockdown with problems of delayed consult, refusal of admission, and limited OR slots. Remember that parents wish to avoid residual deformity and expect to have received the correct treatment during the first visit. Parents have these valid concerns like how much is acceptable and long-term outcomes. And these concerns often lead to sedated manipulation of fracture. These are some of our cases during the lockdown season. A 9-year-old male presented at 1 week post-injury with an overriding fracture of distal radius. Another 9-year-old male with bayonet apposition. And another 7-year-old male who sustained a fall. It has traditionally been reduced under local or general anesthesia. Others advocate reduction in pin fixation because of the risk of redisplacement during immobilization, with an incidence of 22 to 30%. However, these procedures are not without problems and can lead to malpractice suits. Current concepts review of available literature showed published recommendations on acceptable limits of up to 25 degrees angulation and bayonet apposition. This paper compared the outcome of 34 patients who underwent close reduction under sedation but had residual displacement and angulation versus non-displaced fractures of distal radius treated by splinting in situ. Cost of reduction under sedation is 50% more expensive, and there was no noted difference in clinical function and deformity in all patients in this study. In a similar, more recent analysis comparing 3 modes of treatment, close reduction under conscious sedation cost 7 times more than casting in situ and 64% more expensive if you do close reduction and pinning. All patients, irrespective of treatment, achieved full range of motion without any deformity at the end of the study. Since redisplacement is commonly reported complication after close reduction, this paper evaluated what was the cost and claimed that quality of reduction was the only risk factor found to be predictive of redisplacement. Another paper concluded that complete initial displacement and increased obliquity of the fracture line are the most important risk factors for redisplacement. Malunion follows redisplacement and delayed presentation. This paper reviewed the changes that occurred in 33 patients with malunion of more than 15 degrees. There was a statistically significant difference between the starting and the final angulation in both coronal and sagittal views. A remodeling speed of 2.5 degrees per month was also found. The remodeling speed diminished as remodeling progressed, and fractures with greater angulation tend to remodel at a faster rate. Due to the conditions encountered during the lockdown season in this pandemic, like the late presentation of patients due to fear of going to the hospitals, we were inspired by the results of Crawford et al. In their study on the management of overriding distal radial fractures. Although this offers encouraging evidence, it remains a small case series without comparison population. A more recent case control study compared casting in situ versus pin fixation, and results of this study did not demonstrate the superiority of close reduction and pin fixation. Here are the results of our casting in situ for distal radial fractures. A 9-year-old male on presentation, 2 weeks post-casting, and 1 year post-injury. Another 7-year-old male who sustained a fall at 2 weeks post-casting in situ, and after 1 year with full remodeling. Another 9-year-old male patient presented 2 weeks post-injury, and 2 weeks with noted persistence of deformity and almost fully remodeled distal radius at 1 year, with no limitation of range of motion. Management of distal radial fracture with casting without reduction or pinning is a cost-effective means of managing patients with at least 2 years of growth remaining. Casting in situ has no risk of complications of anesthesia or pin tract infection from K-wires. It doesn't even require close follow-up to check secondary displacement. However, it is imperative to explain the natural history of fracture healing and remodeling to the patient's family with the help of clinical and radiographic evidences. Thank you.
This is a case discussion on delayed management of a displaced metadiaphyseal distal humeral fracture in a child. An 11-year-old boy tripped over a plant pot, causing him to land with his left upper extremity pinned in front of his chest. Swelling, pain, and limitation of motion prompted ER consult. The only available x-rays from the emergency room showed a displaced oblique distal humerus fracture that did not reduce on attempted close reduction. A coaptation splint was applied and surgical management was advised. The diagnosis at this time is a fracture, closed, complete, oblique, displaced, metadiaphyseal distal humerus on the left with an AO classification of 13-M 3.14. Due to the Omicron surge, surgical management was delayed, prompting a second opinion with a pediatric orthopedic surgeon via teleconsultation at 17 days post-injury. Repeat x-rays and face-to-face consultation was advised. At 19 days post-injury, physical examination showed a plaster coaptation splint, fading ecchymosis, some residual elbow swelling with cubitus varus deformity, and minimal tenderness at the fracture site with no motor or sensory deficits. Radiographs at this time showed evidence of bridging callus on the lateral, anterior, and posterior cortices. Bowman angle was measured to be 90 degrees with the anterior humeral line shown to cross the capitellum. Gentle passive flexion and extension of the elbow was tolerated at an arc of motion of 60 to 110 degrees without pain. As a recap, we have an 11-year-old boy who sustained a displaced distal humeral fracture 19 days ago on the non-dominant side, presently with bridging callus formation, minimal tenderness, and a pain-free arc of motion of 60 to 110 degrees. Now, what would you do?
Asking the questions to our panel speakers, Dr. Dalo Sumpaico, Dr. Al Legaspi, Dr. Roti. How would you guys treat this patient? So maybe I can ask Dr. Dalo first.
Thank you, Nesty. So, admittedly, we've seen these types of patients even before the pandemic. Coming from a government hospital, not all fractures that we see are acute. Sometimes, or majority of the times, we see them quite coming in late, wherein the albularios or the helots have already tried treating the patients, and these patients end up with us with non-treated fractures already on their way to malunions. So I think just for an overview, there are probably two schools of thought for this type of injury. One, you can actually operate on that patient, or you do not operate on this patient. But whatever your decision should be, you should know what to watch out for or what to look out for in terms of the decision whether to operate or not to operate. So if you are going to operate on a 19-day-old fracture of the distal humerus, and since this is in the metadiaphyseal area, these fractures heal pretty quickly. Maybe two weeks, your fracture line will probably be not visible when you open it up, and you may not be able to distinguish the callus from the normal bone. So be prepared to actually do an osteotomy because you cannot find the actual fracture site to reduce your fracture. Next one, you might have difficulty in the apposition, especially if the fracture has a lot of overriding. So be prepared to shorten that fragment to be able to reduce that fracture very well. Okay, that is for the operative treatment. But if you're not going to operate, it does not mean that you just send the patient home. Okay, follow up whenever there's problems. So when you do non-surgical treatment, you still do the treatment. However, you must do close follow-up. You need to follow up that patient every so closely, maybe every 3 months or so, to see if there is worsening of the angulation, varus valgus angulation, or flexion extension deformity. Okay, and if you recognize any of these deformities, then treat them as needed. So as I said, for this case, whether or not you do it surgically or non-surgically, as long as you know what to look for, I think it will be all right.
Thank you, Dr. Dalo. Any added info? Anything you will do otherwise about the other panels? Dr. Roti, do you have anything to add?
I agree with what Dr. Sumpayco said. Just be just be knowledgeable of what to advise the parents para they can, so you and the parents will be able to watch out for whatever it is, whether it's a loss of range of motion or progressive deformity, and make sure that close follow-up is observed para hindi ma-surprise. Parang super cubitus valgus or cubitus varus na pala, or super may motion block na pala. So,
Correct. Dr. Al, any comment?
Yeah, I agree with Hello.
Go ahead,
Hello.
sir.
Yeah,
Here now.
I agree with the two previous panel speakers. You need to explain to the parents and also to the patient, if they are old enough, about the disadvantages if you will undergo surgery for this type of cases. It's an almost 3-week-old injury. Hello. Yes. Okay. Doing surgery for almost 3-week-old injury is not without complications. Like what Dalo said, you might be surprised with what you'll see inside the humerus. There will be a lot of inflammation, and a lot of bleeding might ensue if you pursue your surgery. But if you will continue with the conservative management, you need also to explain to the parents that cubitus varus or a malunion on the distal humerus does not promise you a good remodeling potential because of the location of the fracture. So you need to observe this and probably watch out for probable long-term complications, and discuss with the patient if he's old enough, if the deformity would be acceptable to them or not.
All right, thank you to the speakers for contributing to the questions, so we can proceed with the case discussion. Dr. Candice.
Conservative management was decided upon with possible corrective osteotomy in the future once the fracture fully heals if warranted. At 1 month post-injury, there was complete resolution of swelling and pain at the fracture site, an evident cubitus varus deformity, and an improved arc of motion of 45 to 120 degrees, and pronation and supination of 45 degrees each. X-ray showed further progression of callus formation and a carrying angle of 8 degrees varus. He was weaned off his splint and allowed to do active assisted, and passive range of motion at home, but was not allowed any loading or weight-bearing activities. At 2 months post-injury, X-ray showed good consolidation of the bridging callus on all 4 cortices with obliteration of the fracture line. Carrying angle on physical examination was 10 degrees varus on the affected side and 11 degrees valgus on the normal side. Flexion and extension arc of motion was at -6 degrees to 135 degrees. Pronation was at 72 degrees compared to 80 degrees on the contralateral side, and supination was at 120 degrees compared to 146 degrees on the contralateral side. At this point, he was able to do household chores like washing the dishes, do his ADLs, and use the computer and play video games. Latest radiographs at 4 months post-injury show full fracture union. Bowman angle is at 85 degrees with the anterior humeral line now bisecting the capitellum. Carrying angle remains at 10 degrees varus grossly and 8 degrees varus on x-rays. Elbow flexion is now equal at 140 degrees on both sides. Pronation is at 78 degrees compared to 88 degrees on the contralateral side, and supination is at 148 degrees compared to 146 degrees on the contralateral side. He is able to do all his ADLs independently, play games, and swim. Now, how would you proceed with further long-term management?
Proceed to answer the questions to all our panel speakers. Dr. Al, any comment? How would you?
Yeah, with the current condition of the patient, I think it is probably wise to just continue monitoring the deformity of the patient. He was able to regain the range of motion into a more functional range, and he can already do active daily living activities for the daily living. We just need to stress to them that the cubitus varus deformity in this problem is not really going away with just a remodeling. Distal physis of the humerus won't contribute much with the remodeling potential, but this deformity is well compensated by the elbow motion, the shoulder motion, and the forearm motion. So another thing that you would probably warn them is the possibility of a posterolateral instability if the cubitus varus progressed, or there were reports of tardy ulnar nerve palsy even with cubitus varus deformity. So just all those things you should be watching out for.
Thank you, Dr. Al. Dr. Arati?
No, nothing much to add. But I think in one of the webinars previously by POSP, we highlighted the magic of remodeling in children. Sometimes you don't expect it to happen in certain areas, but they do. So I think, yeah, just watchful waiting and then proper advice to the parents should be sufficient.
Right. Thank you. I think nothing beats the education with the parents, no? So that they will be assured that even though it seemed like it doesn't lead the way they wanted, but because they were well informed, as we continue our persistence, our resilience for follow-up, they will soon develop very well. Thank you so much. I think I might just accept the question from the participant that is related to this topic so that we will not forget. There is a question from one of the participants, Dr. William. Do you have a particular age group where you would go with outright surgical fixation among these cases? Anyone can answer po.
Yeah, I'd probably take that answer. I do not have a particular age per se of the child, but I would like to have an age of the fracture. I will probably wait for that fracture to mature, to be more, how do you call it, mas matigas, more more hard callus / new bone formation already, not soft callus, etc. So that doing a corrective osteotomy is easier. It's very difficult to operate on bone which is soft, with lots of callus, wherein you don't know where the callus begins and ends, and where the native bone begins and ends as well. So for these, I would tend to wait, maximize remodeling, and then once the fracture is mature, then do the corrective osteotomy. But not in the 19-day, 21, or even 28-day period. Probably wait months before I do surgical fixation.
What's your minimum time frame from the injury?
There's no minimum time frame. I look at the X-rays. So for this, I probably would get X-rays every 6 weeks. If I plan to do surgical fixation, I'd get X-rays every 6 weeks to see to see how the bones look like.
I agree. We just don't, because sometimes you will see them with not so much callus, and you're not confident doing it in a particular time you would want eventually. So it's really more on the radiographic appearance of the bone. All
However,
right.
if it's still moving, if the fracture is still moving, then I still go. You can do outright surgical fixation if you would like to do that.
I think the situation would be entirely different if we get these fractures fresh, especially with the location of the fracture, especially with the vulnerability of the elbow to go into varus because of this type of fractures. But for an old fracture like this, 3-week-old fracture, we would tend to be more observant with the union and remodeling. Thank you.
Thank you, sir. Perhaps I would also do some of additional imaging, CT scan as needed when I'm about to consider a surgical fixation. Dr. Candice, anything you want to add? Thank you for that wonderful.
Can you hear me?
Yes, Doctor.
Yeah, so that's actually my patient. No? So I agree with everyone. So that was the same thought process. At 19 weeks, 19 days, sorry, when I checked the patient, there was liver fracture site. And he was able to actually that came into play in terms of the decision making. And I agree, we discussed all the scenarios with the parent and the patient. He himself understands, and he's old enough to understand. And I think coming from experience also, we learn really to first do no harm to these patients. No? Kasi pwedeng Pandora's box. You open it, you get, end of the day, best case scenario, what's best for the patient talaga. Yeah. That's it.
Thank you. So this now concludes the question and answer portion for this particular case discussion. So I would like to thank all the speakers presenting all the lectures for the POSP section of the POA convention. There is just one question by...
I think Nesty, Candice will present the resolution of the case.
Okay.
Di ba? Natapos mo na ba, Candice? The long term.
Andun na.
Okay.
That was the one.
All right. Okay.
Andun na. Ito there. Yeah, I think that's it.
I think they like the lecture of Dr. Dalo on some question regarding it regarding that. There's a question by I think Dr. Rayan. Dr. Rayan. He's actually covering from leg injuries. Question is, have you, with this technique, sir, the Adidas solution, have you considered infiltrating few cc's of water simulating the local anesthesia? May make the palpation of the tendon difficult.
Yes. So that's a very good question. Thank you, Rayan, for that question. In real life, I do not infiltrate my patients with local anesthesia prior to the tenotomy. I can do the anesthesia after the tenotomy. So I do not infiltrate because of the fact that if I put in anesthesia prior, it makes life harder because it's very difficult to palpate the tendon. So what I do is I put EMLA, I leave it on for 30 to 45 minutes, and that takes care of the skin incision. Once the blade is inside the skin, it shouldn't hurt anymore because the tendons don't have don't have nerve endings, and it's a very quick procedure. So once you twist and cut, once it's out, the baby stops crying. And then if you would like to put local anesthesia, that's a time wherein you put. But in terms of injecting the chicken foot with local anesthesia, you can actually do that. However, because of the cut of the chicken foot on the leg part, we've tried that. When we injected the solution water, the water actually comes out of the proximal end of the chicken foot. So it may make the palpation more difficult, so that you raise the level of difficulty for the model. But we found out that the water spills out on the proximal part, so not much help. But if you do your Achilles tendon tenotomies with local infiltration first prior to the tenotomy, definitely you can still do this and simulate a little bit of masking the tendon with the water or the anesthesia.
Thank you, Dr. Dalo, for that explanation and answer to the question. Very well said, po. I think there are no other questions that was asked by the participants. Time check, it's already 6:05. We are about to close our section and move to the election. But I would like to take this opportunity to summarize the 4 lectures. No? We have presented the challenge of pandemic in one of our most commonly treated cases of clubfoot, but the resilience coming out of the heart of the orthopod, pediatric orthopod, to reach out far-flung areas never stops. And what never stops also is the education. As far as the ingenuity among our pediatric orthopods, that Adidas solution. Thanks, Dr. Lalo. It is simple, it is practical and transferable learning that not only can be applied locally, but even internationally. And then we proceed. Then we proceed to one of the most common trauma treatment among children, the distal radius and the elbow. And this is one of the cases during the low cases when the COVID cases went down. No? They are outside. And that's why we see most often yung mga cases na ganito. I think for me, the summary is that treatment and education ingenuity never stops in pediatric orthopedics. And that's why we are here to help you, our colleagues, our patients, the parents. This is a collaboration between us, the surgeons, the rehabs, and the members of the family. So treatment and education and ingenuity never stop. So once again, in behalf of Pediatric Orthopedic Society of the Philippines, thank you for listening and joining this and listening to these wonderful lectures among our panel, Dr. Sumpayco, Dr. Candice Lim, Dr. Ale Gaspi, and Dr. Roti Flores. Good evening to everyone.